Hello, everyone. It looks like we are already recording, and the First Lady will be here very soon. Good to see you all.
Hello, everyone.
Hello.
Taylor, you say when it's time.
Okay, I think we're getting close to having critical mass, and we're already recording, so
Yeah.
maybe just a minute more. Okay, First Lady, I think we have critical mass.
All right. Hello and welcome. Welcome back to the Behavioral Health Talent Council. Um, as always, this meeting is being recorded. Today is the third in our series of meetings focused on highlighting profession types. Um, the ones that the tech talent assessment is identified as being a projected shortage or high risk of turnover. And so this series, we're gonna talk specifically about mental health providers. Um, our last meeting was dedicated to psychiatric medical professionals, then addiction providers, and then today's mental health. Our next meetings will take a deeper dive into peers and then the youth focused workforce. In addition to my incredible vice chairs, I want to thank the council members who lended their expertise to build this meeting's agenda. Julie Ibrahim and Shira Mirala Simmons now, I see. Uh, there might have, seems like something might have changed. Maybe congratulations. And thank you for everything. After the presentations, we're going to move into successful strategies. We'll hear from La Clinica, Laura Bridges, Behavioral Health Officer, and she's going to speak about their fellowship and internship program and their successful strategies to recruit and retain linguistically diverse populations. Afterwards, Julie Ibrahim, Executive Director of New Narrative and Vice Chair of this council, will present on New Narrative's successful application of AI in clinical documentation that they've had success with reducing administrative burden and helping to retain workforce, as well as some other initiatives that they do. Then after a 15-minute break, Shira Mirala Simmons, the Executive Director of Classic Behavioral Health and member of this council, will present on their CBHC's um, 4-day reduced work week and grow your own strategies for organizational culture. I want people to know I visited both of these places and they are doing incredible work. I am just excited for you guys to hear about what I saw because it's leading the way. Our last presentation will have Dr. Hope Sherman, Senior Clinical Education Educator Director at Eastern Oregon University. And they'll present on barriers and opportunities in the education and training space. They have a program at Eastern that is really incredible and exciting. And they're doing great work there, helping us build the role pipeline. And then we'll wrap up our time together with some group discussion to talk through what we learned and how it applies to the work of the council head. So we are going to move into the agenda. Our incredible Amy Baker is going to do an overview like the last meeting about kind of the mental health provider 101 and the professions that we're encapsulating today. And so take it away, Amy.
Thank you, First Lady. Uh, so I am, as the First Lady mentioned, we have parsed out the system in different chunks so as not to do the odyssey of the behavioral health system at all at one time and put you all to sleep. So today we're focusing on mental health, excluding peers and medical professionals, because they will have their own special attention. Next slide, please. So this is a really simple diagram of what the mental health care system looks like in Oregon. Starting at the base of the triangle is really prevention and promotion, and that includes things like crisis lines and primary care screening. It's the way that warm lines, way that people like reach out and we start to identify folks who may be struggling. When we think about mental health, the bulk of the system is up from that. And so that includes community-based outpatient services. That could be individual therapy, group therapy, psychiatric medical care, peer support, et cetera. And then we start to get into more intensive services. And on the adult and kid side, that's things like assertive community treatment or intensive outpatient, wraparound. We don't do ICTS anymore. IIBHT, things like that. Residential services and subacute that could include secure foster care. And then in the orange, we have acute inpatient, like psych units, and then the top of the pier is the Oregon State Hospital. And you'll see the line on the side includes crisis services because people may access crisis services anywhere along the continuum. And I think what you will find in Oregon where we're struggling the most in terms of hiring is really in the levels of care that serve clients who are in higher acuity. So the intensive outpatient, crisis services for one. You'll hear Shira talk about the issue for mobile crisis clinicians and not having a pathway towards licensure in order to promote professional development. And then of course, residential is another area where we've like really struggled to hire folks. Next slide, please. So we already covered licensure, but I just want to go through it again really quick because it's such an important part of the mental health system. This shows the licensed professional counselors and the LMFTs and the number of folks that we have and the psychologists, number of folks that we have in the field. And I think one of our challenges right now in terms of data collection is figuring out how many of the licensed folks are still operating in the community behavioral health system. And it's certainly been a point of discussion around ensuring we have enough licensed clinical supervisors in order to provide licensure supervision for the community behavioral health workforce. Next slide, please. And so for LPC, again, just a reminder that these are the hours that are required in order to gain one's license. For LPC, it's 3 years and 1,900 direct client contact hours. And the same for LMFT. The benefit being that at least one of those years can be pre-degree in order to get graduate students sort of a head start on that process. Next slide, please. And then with our social workers, we have 7,200 LCSWs who are regulated through the Social Work Board. And I have another 1,954 of the CSWAs. Those are the Certified Social Work Associates. Next slide, please. And I think the other thing that you will find is that a lot of like the CSWAs and the pre-LPCs tend to be more present in the community behavioral health system. As I said before, like the challenge is that a lot of times when folks get their license, they end up going on to private practice. So for LCSW, the requirement is 100 supervision hours, including 2,000 direct contact hours. And the CSWA, basically you have to have a board-approved plan of supervision, so you have to be receiving clinical supervision from a approved licensed supervisor. Next slide, please. We also have the QMHPs and the QMHPCs. The QMHPRs are the registered interns. And the Cs are QMHPs who have a little bit more supervised clinical hours, and they have to pass a competency assessment. And these folks may or may not be in the track to get their licensure. Next slide, please. QMHAs are also another sort of really important part of the mental health system. You will often find QMHAs working with clients with higher acuity. That could be in positions like skills training or case management. And to become a registered QMHA, you either have to have a bachelor's degree in a relevant study, so like psychology, social work, and that sort of thing. And then you advance in your QMHA status as you gain more supervised clinical hours, going up to the QMHA2 at 4,000 supervised clinical hours. Next slide, please. And so again, to remind you and to balance all of this in the work that we're doing as part of the talent assessment, we see that there's a projected workforce deficit for some of these positions, particularly mental health counselors and child and family social workers. And so that's why we're setting the stage to have this conversation, and so that you obviously you'll know why we're working on this. Next slide, please.
Okay, questions? Clarissa looks like maybe, no. Okay. I have a question, maybe it's a point of clarification. I think we, just around, supervision, and when we are talking about when people are getting, Amy, when people have to pay for their own supervision, what's that costing these days?
Yes, that's right. I did mean to talk about that. Thank you for asking that question. So, so it is true there are cases where you have somebody who's trying to get their licensure supervision and they're having to pay out of pocket for that supervision. I think the going rate is like around $150 an hour. It could be a little bit more, a little bit less, depending. Oh, Shira's saying up. Is it $200 now? Yikes. It's gone up since I left CBH. Wow.
Yeah.
So yeah, so that would potentially be an expense at $200 an hour if somebody's working for an organization that doesn't cover that.
Thank you. Okay. And then one other thing, I think everybody just want to double check, if people know what an ACT team is for the most part. Okay, great. I think we're good to move on then. Thank you, Amy. Let's see. Now we're going to move up. Okay, so now I want to hand the floor over to Laura Bridges, Behavioral Health Director at La Clinica. As we move into stress, we want to talk about the successful strategies. Laura oversees La Clinica's behavioral health services as a behavioral health officer. Laura holds a master's in social work and public health from Boston University and serves on the Jackson Care Connect Board of Directors. Laura, are you ready?
Yes, I am. Thank you. Thanks for having me. I'm gonna share my screen if you'll give me just a second and let's see. Hopefully this will work. Can you see my slides okay?
Certainly can.
Great. Okay, wonderful. Thank you. Thank you, First Lady and Talent Council, for having me. I'm excited to be here. My name, as Amy mentioned, is Laura Bridges. I serve as the Behavioral Health Officer at La Clinica. I'm going to share a little bit about what we're doing with workforce development and behavioral health. Just to quickly ground you for who we are at La Clinica, we're a federally qualified health center, very much grounded in our mission, and that's really what draws most of our employees to join our team. We serve the people who need us most through exceptional, affordable, and compassionate care, with the goal of inspiring all those that we touch to lead full and healthy lives. We've grown over the years from one Phoenix Health Center back in the late 80s to now having 33 sites. We have 6 community health centers. We've opened an acute care clinic. We have one standalone dental clinic as well as a dental clinic embedded in one of our health centers. We have 20 school-based health center sites across the valley that offer specialty mental health services. We are at the Student Health and Wellness Center now at Southern Oregon University. We are embedded in Aura, which is a transitional housing and resource center for the houseless community in Ashland. We have a community pharmacy and a mobile outreach team, and then our Center for Learning and Innovation, which really offers workshops and wellness classes for the community. We have 525 team members, 123 of whom are bilingual in Spanish and English, and 54 of whom are certified and or qualified interpreters. This will give you a breakdown of how many of our team members are medical providers, behavioral health, and dental providers. Just a quick snapshot of who we served last year. We served over 29,000 patients in our community, with over 121,000 visits or interactions. And I just wanted to provide some data so you could get a sense of who we're serving. 61% of who we served last year have Medicaid or OHP for their health insurance, and 11% are uninsured. 63% of who we serve are at or below the federal poverty level. And we track certain special populations to know who we're targeting in our care. And so 4,600 folks were unhoused last year that we served. Agricultural workers we were able to reach were 1,700. In the community, 22% of who we serve prefer care in a language other than English. And over 2,000 of whom we've cared for last year identified as LGBTQIA+. And so my hope is to just share a little bit about who we are as an FQHC, ground you briefly in what our model of care is, and then I'll dive into what we've done to grow our workforce. La Clinica's take an approach to behavioral health care, and it's kind of similar to what Amy just shared, but will look a little bit different in this pyramid. But we do take an approach of stepped behavioral health care for the community that we're caring for. And so really, as we move up the triangle, we're thinking about people's needs increasing based on their symptom severity and requiring a different intensive level of care as they move up the triangle. At La Clinica, where we're really centered in our care delivery is going to be in these first 3 areas, and I'll walk you through that. And so we're really taking a population-based approach to healthcare and to behavioral healthcare in the primary care setting. So for prevention and support at the base of the pyramid where we're engaging people, we're offering wellness classes through our Learning Well department, which looks like Zumba, yoga, diabetes prevention, mindfulness classes. And we also have this role, the behavioral health support specialist, which is a QMHA level in our care teams embedded in our primary care clinics, providing lifestyle coaching to the patients that we care for. When people need more support, we step them up, so to speak, meaning that we start to provide short-term interventions in the primary care home. We have integrated behavioral health clinicians who are master's trained providers that are working on the care team alongside the primary care provider to provide targeted therapeutic intervention. And this could be around hypertension, diabetes, anxiety, depression, substance misuse, any number of conditions. Really, the goal here is that we want to be available the same day that a need is identified. And so we're really focused on a rapid access to behavioral health care. When people need more care, we step them up, meaning that we continue to provide care with that integrated behavioral health clinician and primary care provider. And we also offer integrated psychiatric consultation to help support our primary care providers in holding that patient within our health center as much as we can. So they're providing shared visits with the primary care provider, doing consultations, or they may take a referral and do a short episode of care for a patient who needs some psychiatric management to stabilize them and flow them back to their primary care provider. Or identify that they need that specialty level of care and then bridge them to get into our community partners who deliver that specialty care. When they need specialty care, where we're going with that is we're connecting our patients to long-term mental health and substance use services. For adults, that's our community partners. For youth, that's still with us in our school settings where we're offering long-term mental health therapy and skills training in a COA type environment within our school sites. And then our highest level we like to think of is our inpatient residential and ACT, and really our role in that is we are referring, we're doing care coordination, we're still holding those humans in primary care, but we're very much care coordinating with our specialty partners to ensure that they're getting their mental health and substance use needs met. I want to highlight this because as I talk about our workforce challenges, a big part of what we're really trying to accomplish is to create access for people the same day the need is met. And that's what the integrated behavioral health model has helped us do. Rapid access, as well as improving quality outcomes for folks. And so we're able to serve a large number of people in our primary care setting. And by doing that, we're creating, our intention is, and we hope and believe we're creating access in our specialty partners because we're not sending everyone to that. We're really sending the people who truly need that level of care. Many people aren't needing long-term therapy and case management. Many people need their needs met can get their needs met right in primary care, and that's what we're trying to do. So the challenges we faced are really recruiting and developing a bilingual behavioral health workforce. And I'll talk about our strategies that we've done with this challenge. Similarly, like I think many, we've struggled to recruit and retain clinicians at the master's level. And then what we've really struggled is to help clinicians learn the integrated behavioral health model that is a team-based model of care and is a paradigm shift from what clinicians are trained to do in master's level programs. So a lot of work and challenge there. We have fully accepted that we want to grow our own, that that's how we're going to get there. And we believe that we're going to grow our own and or grow staff who will then move into the community and work at our community partners and continue to serve our community, meeting the health needs that we see across the community. So we created this pathway to help our staff understand how you could enter into behavioral health, not just our staff, but also in the community, how you could get in with behavioral health. And particularly, we were trying to target our front desk staff, our community resource specialists, our MAs, our bilingual workforce that often is coming into healthcare in these direct entry roles and don't see a path forward because it seems too hard to get into behavioral health. And so the role of the behavioral health support specialist in primary care is an entry point for them. We provide all of the training and support to them when they join our team. And we show them a pathway forward where they can move forward to eventually get their QMHA certification, where eventually if they want to go back to school, we offer opportunities for loan repayment. We also explain to them, if you want to go back to school and get your master's degree, we'll support you and pay you to do your internships with us. So we keep them whole while they do their internship with us. When they graduate and they join us as an associate, we'll cover your clinical supervision. And if you stick with us, when you get licensed, what we'll do is we will increase your pay. We'll give you a pay because that's a lot of work. As you just saw, it takes a lot of hours to become a licensed clinician. We'll increase your pay. We will give you the same continuing education credits we give our primary care providers. So really wanting to show them there's a way forward and we're there all along the way to support them. That QMHA role for us It's not a requirement in primary care to have your QMHA, but it's a durable credential that helps people move around the community. And so what we found is it's a great way to help our team members get trained, feel competent and able to do the work. And it's a great way for us to bring in people who are bilingual. They learn how to be a behavioral health team member, and many of them have come in as interpreters or become interpreters. And what that's done is let us allow, they've been able to interpret for our behavioral health clinicians, which has improved the care of our patients because they are trained already in behavioral health and they're interpreters, and their ability to do the nuance of tone and engagement with patients is different than other interpreters. And so not only can they do that well, they also are just learning as they're working with clinicians side by side to do some of this. So we're seeing this as a cool strategy to bring the bilingual workforce into behavioral health. We have other places that we support QMHAs in our pediatric mental health team, as well as doing some brief substance use screening and intervention. And we've really relied on community partners for some of those training supports. So SOU has helped us by offering micro-credentialing for that workforce. And then also we've worked with Continuum, who has the on-pace apprenticeship, to put some of our team members through that to become CADCs. From there, as they move into that role and become credentialed as QMHAs, our goal then is to get them to go back to school and become clinicians. And so when they do, we offer placements in integrated behavioral health and in our specialty mental health program in the schools. We pay for them to do their internship with us. We also have started offering thank you payments to our clinical supervisors because staff are holding these interns, and it is a lot of work and it is exhausting. They do a tremendous amount of work to coach these new people coming into the career. And so we want to recognize them. It's not easy, and you have to love teaching, and it's a lot of work. So we recognize that. I think a struggle I'll call out here is that in our school sites, it's under a certificate of approval, so we're able to bill for those interns, and that helps sustain the cost of this. In integrated behavioral health, we don't have a certificate of approval because it impedes integration, and so we can't bill for their care. So we really depend on grants to help us support those interns. But if we don't have an internship opportunity, we don't have an integrated workforce, because what we've learned is we have to train interns in integrated behavioral health to grow that workforce. Learning while they're in school is our best bet. When we bring licensed providers who've been doing specialty care for a long time, it's too hard to make the shift for many of them. Some people can do it, but many struggle. And so this has been crucial to our growth in our integrated behavioral health work. And our final step that we've just started to embark on is our effort to develop a fellowship program. For those of you who don't know, the clinic has started an advanced practice provider residency back in 2023, where we started training new grad PAs and NPs in primary care so that we could support that workforce growth. It's been really successful. Our second cohort's getting ready to graduate, and what we're going to do now is embed an integrated behavioral health fellowship within that residency. What that means is new graduates will get to join us for a 1-year-long training program as a fellow. Well, they'll get specialized training and support to grow their skills in integrated behavioral health right alongside residents. They'll get precepted clinics. They'll go to weekly didactics with residents. They'll also get to rotate out in the to some of our sites with mentors. And then our hope is to have them shadow some of our community partners in higher levels of care, so they understand the system that they're working in and when they can hold a patient in primary care and when we step them up. We're looking forward to this starting in July. We have a belief that this is going to really help us both attract and retain our integrated behavioral health staff, which will help us then serve our community largely that is doesn't always need specialty care. And we can do a lot around health behavior change and really support people where they're at and through their lifespan. We're not episodic, we're just here. We're here whenever you need it. We don't close services and open services. You just come in as you need the care, and we're there for you same day. I think that's what I've got. Questions? And I'll stop sharing.
I don't Oh, sorry, Jamie, you've got a question.
Um, y- this may be beyond the scope of the conversation. I was curious when you said that a COA impedes your ability to do integrated care, if there's just like a thumbnail sketch on that, what that means.
Absolutely. I don't know if I have a thumbnail sketch, but what I'll say is we removed the COA about 5 or 6 years ago when we realized that our goal is we're bringing people in for care. They're consenting to join us in a primary care home that includes whole health care, behavioral health included. And so it was impeding us when we get a warm handoff to have to sit down and go through a cumbersome mental health treatment intake packet. We'd have to do a comprehensive assessment. We'd have to do a treatment plan, and then we could serve them. Instead, what it looks like now
Yes.
is I see you today, you have an issue with anxiety, and today we do work on that anxiety. And I don't have to do all of that. I can get that over time with you, but I can work with you today, and you can leave with some plans and skills.
That's super helpful. Thank you.
Yeah.
Tyra, yeah.
Just to like clarify a little bit more around that. So you're still serving the Medicaid population though, right? Okay. So I've heard, so in conversations about like how cumbersome the intake process is for COA organizations, I often hear the rebuttal to that is, well, those are federal Medicaid standards. This isn't a state decision. But that's not what I'm hearing from you and how you guys operate your clinic, that it is in fact the COA and the OHA expectations of operating COA that require the full psycho or the mental health assessment comprehensive service plan, and that these pieces be in place, given they did change the rules, so we have a little bit more time to get those things done now than we used to. But I'm just I'm curious about that.
My understanding is that they come through the OARs, the 309 OARs is what guides our COA requirements through the state. So we operate under the 410s because there's not really any actually structure for integrated behavioral health currently in the state that kind of guides what we do. But we have all of this information from our primary care providers. In integrated behavioral health, we're not serving folks who haven't yet come into our system and seen a primary care provider. So we've got, a history on them. We've got diagnosis on them. We're already starting to work with them. So that's my understanding. I've heard it to be a state decision to have a certificate of approval. I've not heard it to be a federal guideline.
Yes. It's a state decision to have a COA. And yes, the 309s guide that work, but I've heard that they're rooted in these the federal expectations around how Medicaid services are rendered in the behavioral health setting. So I thank you for clarifying.
Marissa?
Thank you. This might be a really silly question, basic question, but it seems I saw your flyer last week and I was really intrigued, but it seems like this is geared towards therapy fellows, not necessarily. It's hard because the language says providers, and I never know if that means medical providers or if that means, and you're speaking about SOU. So I was feeling like it was more a therapy tract than necessarily like a psych and P tract. Am I correct or am I wrong in that?
The fellowship is targeting master's level integrated behavioral health clinician providers. It's not a psych and P track. And so we call them providers, behavioral health clinicians or consultants, but it's not, I wouldn't call it a therapy track. It's a team-based integrated behavioral health track. So they won't set up a caseload and serve 40 to 60 folks in weekly therapy. They'll instead serve about 33,000 people coming in for primary care, and there'll be consultants and direct providers for that population in their primary care team. Does that?
So they work alongside the medical professionals. Because when you say integrated behavioral health, that's also us. That's a psych and P also,
Yeah,
right? So it gets really
absolutely.
tricky for me to understand, like, is this a psychiatry or, a medical provider program, or is this other?
The advanced
Thank you.
Practice one is for medical providers. The integrated fellowship is for master's level team members. And
Oh, so you have two.
yes, we do have a primary care medical advanced practice provider resident.
So just for primary care. Gotcha. Okay.
And these folks will work alongside them in the team-based model of care. Does that help? Sorry.
That makes sense. And I will point out, I know that there's been discussion about providers and what terms people use. And there's been, and I want to appreciate that and understand that we are going to go with the language that people use and different. I know a lot of community mental health to say providers. And that can be a catch-all. And I know that there can be some feelings about that. But thanks for the clarifying question. I just want, Taylor, are you giving that we're almost time? Okay.
Yeah.
Laura, that was incredible. And it touched on a whole, I mean, I just was incredible. There were so many things about it that were incredible. The pipeline, the picture. I also want to say I love that you talked about the front desk because the front desk is the front line. And I have seen over and over and over. If you can do the front desk, you have the resolve to do the work in the clinical rooms. And I've seen multiple people do it, but I've not seen it kind of called out in that way. And I just think that's fantastic to really identify those folks as pipeline. Because I'm sure we've all seen that in these clinics. But to see that, to be able to imagine your future, just that alone reduces barriers and makes people more excited to go in. So I just want to say thank you so much. I could see everybody, people are writing. I mean, lots of opportunities there. So thank you.
Thank you. Thank you so much for having me.
Okay. And then I think, so now I'm going to turn it over to Julie, Julie is the CEO of New Narrative, a nonprofit providing mental health treatment, housing, peer support services in Multnomah, Washington County. She brings over 30 years of experience leadership. Wait a minute. She brings over 30 years of leadership experience from Fortune 500 companies and mental health agencies and is a licensed counselor in Oregon. Julie, you ready to go?
Thank you. Thank you, First Lady. I'm going to try and share here. Okay, can everybody see that? Okay. All right. Good afternoon, everyone, and thank you so much for the opportunity to speak today. Today, I'm going to share a few strategies that we have found to be successful in retaining our employees. I'm focusing on retention because we found that successful retention leads to successful recruitment. Many of our new hires have told us that they come to New Narrative because of word of mouth about our culture, and especially folks that we employ that are identifying with marginalized communities. But I'll talk about that in a minute. First, I want to talk a little bit about who we are. We are a nonprofit mental health agency providing mental health treatment and psychiatric care. We work under a COA. We provide peer support and housing services, as well as a continuum of housing, including residential treatment, transitional housing, supported, and independent housing, because we feel that housing is healthcare. And we serve adults ages 18 and older for over 48 years. We practice team-based care in our residential facilities, the licensed facilities, and we are starting team-based care in our outpatient facilities this very quarter with a grant from Care Oregon. We serve adults and transition-age youth with moderate to severe mental health challenges, most of whom receive Medicaid through Care Oregon and Trillium. I forgot to mention, we have a special program for transition-age youth that are aging out of the foster care system. And I'm not going to go into detail about that because we don't have time, but youth services is starting to be a growing program for us in conjunction with DHS Child Welfare. We operate in Washington and Multnomah counties. Okay, I'll share a few key numbers to give you a sense of our size and scope. We serve about 2,000 folks a year. our total beds in our residential portfolio among the whole continuum, 340. We have 43 sites spanning from Cornelius in Washington County to Gresham in Multnomah County. We have over 260 staff, including a fluctuating on-call pool. About half of those work in some portion of our residential portfolio. This is our staff diversity profile, and these are folks that are voluntarily identifying. So lived experience is 40% of our workforce, LGBTQIA is 27%, and BIPOC is 44%. I really think these numbers are higher because some folks are just choosing not to identify, which is fine. Our operating budget is running about 40 million at this point. We have literally doubled in size, more than doubled in size in the last 4 years. One of the first things I did when I became CEO about 4.5 years ago was to assess company culture. When I first started at New Narrative, which was formerly Luchtdorf, we had what I call a parent-child culture, characterized by fear, authoritarian leadership, lack of trust in leadership, no feedback to leadership, a lot of negativity, and turnover rates well above 50%. So for the last 4 years, we've been working to transform our culture, which has led to a significant decrease in turnover. I call it team culture, with the objective of being inclusive and safe, power sharing, employees trusting that leaders have their back, a significant increase in feedback, much more energy and positivity, and a decrease in turnover. To date this year, it's 36%. I still don't love that number, but it's quickly moving in the right direction. So I'm going to talk about 4 different areas of success strategies: employee support, communication and feedback, relieving administrative burden, and team culture investments. So employee support. We started with an understanding and acknowledging key things about what I will call the new workforce. And it's not just the Gen Zs, by the way. And I've done a lot of reading and research on this. A really important thing to know about today's workforce is that anxiety is prevalent and all-consuming, and I'm sure you see that in your own workforces. The statistics you see here are increases in self-reported anxiety over the decade between 2010 and 2020. This is from the book, The Anxious Generation. I was rather stunned by these numbers, frankly, and it helped me start to understand why our workforce seems so burdened and overwhelmed. We realized from staff feedback that it is important to today's workforce to acknowledge and address the sources of their anxiety and how our agency would be responding to them. That these issues actually impact their mental health and their performance at work. Things like national and world geopolitical events, cost of living, systemic racism and oppression of marginalized groups, and of course, budget cuts. So we quickly came to the conclusion that we needed to support our workforce in a more holistic way. We found from extensive feedback that employees want support for their identity, they want to be included in decision-making, and they have a need for community in the workplace, especially for our employees representing marginalized groups. So we started there. We set up affinity groups for LGBTQIA+, BIPOC, and lived experience, and made it policy that supervisors have to allow employees time to attend these groups. We also set up an equity and action committee to advise on policy and procedures and communications to make sure we're in alignment with our values and our equity statement, which they produced, by the way. We held extensive listening sessions with our affinity groups and the EIA committee. I went to every single one of these to hear their concerns and to respond with action items, such as bringing in consultants for training regarding equity issues. Another really important step towards creating an inclusive culture was to include middle management in strategic planning. We just started that this past year, and the results have really been great. Not only are we getting more robust input to strategic plans, but the executive team is getting much needed help on implementation. And we also established 2 annual all-team in-person events that are just about having fun. No agenda, just about having fun, both of which can be attended by family members as well. A huge component of our cultural transformation has been communication. We communicate exponentially more than in previous years with multiple modes of communication and repeating important themes such as strategic initiatives and response to ongoing events. Recently, the ICE raids, we've sent out a lot of information and communication about those and guidance for our workforce. We tackle the hard subjects with transparency to instill trust. For example, I've spoken openly about the budget challenges we'll be facing in the coming years and how we're preparing. I don't respond to all political events, particularly wars in other countries, but I do comment on events that have impact on our agency and community. We try to balance our communications with content that is celebratory, inspirational, and just plain fun. Here are some examples. We do an all-team meeting every quarter. It's virtual. And we generally cover strategic initiatives, financials. We address team anxieties, whatever we feel is bubbling up at the moment. We highlight specific programs because we're spread out in a lot of different programs over a wide geographical area. So folks have expressed the concern that, hey, I'd like to hear about what some of my colleagues are doing in other parts of the agency. So we've made this a regular thing now to highlight programs. Of course, there's gratitude and shout outs, and there's an Ask Anything Q&A. We also have an in-person all leadership team meeting. Many of the topics are the same, but we go into much more depth. We take more time, and we have a lot of group bonding activities. And these are leaders from every single level of the organization, everything from leads to supervisors to program managers, directors, and executive team. One communication tool that has been surprisingly effective is an email that I sent out to the entire workforce every Friday. I started this my first week as a CEO, and I got such a good response that I just kept doing it. I usually provide gratitude and shout outs. I give announcements about our agency or the community or the state or the federal situation, whatever is going on that's of interest at the moment. We have a program spotlight. And then importantly, I include thoughts, my thoughts, some inspiration that I found, some humor to lighten the load for folks for the week. There's been a tremendous response to this. 60% to 75% of the workforce read this every week. This email is not just a communication tool. I think that by getting to know me as a person, it instills trust in leadership. A very important element of our transformation journey has been to create a culture of feedback with consistent response and action. Some examples. We have a very comprehensive all-team survey with 44 questions across 8 categories. We've been doing this for 7 years. It has grown in response rate from 31% to 78%. We do comprehensive reporting and analysis. We follow up with in-person meetings with each department to help validate results and get even more qualitative feedback. All team announcements about action taken are, as a result of the survey, go out. Sorry. And I think the reason why there's such a high response rate is we show the receipts that we're listening to the feedback and taking action as a result of it. Here's just a few other examples. I'll go through them quickly. We have an online suggestion box called Suggestion Ox. I read every one. We respond within 24 to 48 hours. Anybody can meet with me. We have executive listening tours. We go to sites every quarter, and once a year, I go to every single site and talk to frontline staff. We have pop-up surveys on hot topics. We include 360-degree feedback in annual performance reviews. And of course, in our clinical setting, we do feedback-informed treatment and participant surveys. Now, we have been getting consistent complaints long before I was the CEO about employees having too much administrative burden, particularly documentation. For the last couple of years, we've been installing software tools to help ease administrative burden and facilitate communication. For example, we installed Microsoft 365 and utilized Teams and SharePoint extensively. But the real game changer for our clinicians has been using AI to write their session notes. A few years ago, we got a grant to purchase a behavioral health AI platform from Elios Health. They have been around for, I think, about 2 decades and have a lot of behavioral health intelligence accumulated in their software. They are compatible with most EHRs. They're HIPAA compliant. There's excellent training and customer service. And what the software does is actually listen to a session, not transcribe it, although you can get that option. It listens to the session and produces high quality clinical notes that are based on evidence-based practices. What I also like, it provides a lot of analytics for the clinician. It will tell you what modality you're using in the session. It will tell you what percentage of the session did the clinician talk versus the participant. So it's good for supervision and analysis. It's HIPAA compliant because once the session is done, the clinician can either edit the note and send it on to the EHR, or they can accept the note as is and send it on to the EHR, or they can reject the note and completely write their own. Once they make that decision, then the session is no longer stored in the system. So the session goes away because it's already been documented in the EHR. Our QMHPs and our QMHAs use it in outpatient, PSRB, and ICM. The benefits are notes are now completed on time. It used to be our clinicians would take weeks and sometimes months to get their notes done, and we had to, move to disciplinary action on some folks. Now notes are completed on time, and there's a reduced time to complete from 15 minutes down to 7 minutes. This has increased staff capacity. It's reduced staff anxiety. Oh, there's so much anxiety about doing documentation in our younger staff, and it has increased staff morale. Oh, Taylor's giving me the sign. So I won't go into detail about these last 2 things. We have made a couple of investments in team culture training. One's called the Loyalist Team, and one's called Insights Discovery. If you're interested in any of that, I'm going to put my email in the chat and I can send you more information about it. Any questions? Take down. Share. Shira.
Yeah.
That was wonderful, Julie. Thank you. And I didn't say thank you to you, Laura, but your presentation was also amazing. So thank you.
Yeah, your presentation was very slick, Laura.
It was very slick. I was like, uh-oh, mine's not that slick.
That's what I was saying.
I am so curious about the Elios Health software, and so want to set some time with you, Julie, to talk more about it, maybe outside of this space. But I'm curious about cost, because that seems to be our primary barrier right now, especially in this climate.
Yeah.
It's just how do we carve that out and invest in it? So what does it cost?
Yeah, I'll make a quick comment on that. I'll share the contract and everything. And frankly, Care Oregon paid for it for us, but they're not going to extend it. It is pricey. It is a 6-figure situation over multiple years. However, many EHRs right now are integrating AI. And so if your EHR is integrating AI, I would recommend going that route. In fact, we're with Credible, and they have introduced an AR product. We're going to try it out because we're just not going to be able to continue the funding for Elios. Elios is a great product. It's expensive, but there are less expensive alternatives if you go with an integrated EHR. But it has really, truly been a game changer.
Thank you. I would just like highlight here that this is new for us, right? Like it's new for everybody, this AI boom. And so we've never built this kind of like operational cost into any of our operating budgets ever before. And so that's just something that the system needs to consider as we think about funding the behavioral health system moving forward, because the costs aren't going to go away.
Yeah, and we've had many discussions along that line at OCBH about that too. All right, thank you very much.
Okay, there's one thing though, that I might have to, fantastic job. I would also say, we talk a lot about trauma-informed leadership and like, that's what that looks like. I mean, I want to just map that, I want to call that out, right? Because it's providing the information, it's taking down people's temperatures, it's doing all of those things that make people want to stay. The word gets out, word on the street is that's where you want to go work. The word is out there. It is that the best recruitment is good retention. I don't know, we got to figure out how to fit this in, even if it's not today. Julie, I'm sorry if I'm putting you on the spot. But one thing I learned that kind of blew my mind, when I went to go visit Bridgeview. Is that right? Is it Bridgeview?
Mhm.
They're doing something. And I want to say, Julie, this might come from your previous background, but they're doing something that's super innovative in that not everybody who's a supervisor has to be like you can be a peer and be a supervisor, and they get clinical supervision somewhere else. Because being a clinician and being a boss may or may not be everybody's same goals, right? And you may have somebody who's been a supervisor at a different organization or had 20 years of supervising staff, and now they're in a QMHA level. But so that was just like mind blowing. And it really kind of gets to some of these things that we've talked about in the past around, people move up into being supervisors because that is what they need to do to make ends meet, not necessarily because that's the work that they want to do. And it just creates this really incredible flexibility. And so I suspect that other people would be interested in hearing more about that. And so we add that somewhere? I know we're behind. I want to keep rolling, but I actually think it's just really innovative and is worth talking about again. And so maybe we fit it in the but it is so interesting. And really I think is making a difference and just gives more flexibility to I think who can do what and workload.
Yeah, we're taking a really hard look at that with a pay and performance project that's in process right now that we got a grant for. Where do we really need a credential and where do we not? Are there other pathways besides supervision? Because there's a lot of people that don't like supervision, but they want to advance. And so we're in the process of really trying to figure out what are some more creative ways of providing a career progression that is not traditional corporate pyramid stuff, to put it kind of simply.
So good. Just so good. Okay, I will it's time for a break and I was so interested. I don't even know where we are or what's happening.
So we could do a short break for 5 minutes, coming back at 3:05, or kind of a medium break till 3:10. Both of those would mean cutting into discussion by about 5 or 10 minutes, but we have about 25 minutes held for discussion. So those are some options for you.
5. Oh, okay. So it is 3 o'clock now. Let's break. Come back at 3:05. Stay in the chat. Turn off your video and your audio.
Handle them. Hold on.
Taking in. Okay. Okay. Okay, I think we're close to critical mass. And I know sometimes you have a break and then something happens, you get a phone call, understood. You're all doing important, busy work. But I'm gonna keep us going. Um, uh, next, mm, um, next up, Shira, Marilis Simmons. Simmons? Yes, is the executive director of Classic Behavioral Health. She's been in a leadership role since 2016. Previously, she worked in clinical leadership at Griffith Center for Children in Colorado, providing intensive services and home-based care to families and youth. She's served on the HB 2235 Behavioral Health Workforce Work Group and the Association of Oregon Community Health Program Legislative Committees. And like I've said, I've had the opportunity to go to the clinic. I will tell you that they have such an incredible labor management partnership, one of the best I've seen. And I'm just super excited to. They've also really figured out some things around residential that I think is really illuminating for folks. So if you are ready, we are ready for you.
I'm ready. Can you see
Okay.
that?
You sure can.
Okay, great. So yeah, thank you, First Lady. I'm Shira Marilis Simmons. I got married last June. It's been over a year, but the name change sometimes takes a while. Yes, and yeah, I'm the executive director and licensed professional counselor with Classic Behavioral Healthcare. I've been with CBH since about 2016. Prior to being the executive director, this role I've been in for a year, I was the deputy director, and just want to honor that Amy Baker was the executive director at CBH for about 9 years, and that we really did this together. So just want to honor that this was a team effort. Okay. Wait, I guess I should go from the beginning, right? Sorry, you guys. Okay, there we go. Wait, now I can't see you all, but I guess that's okay. Okay. Okay, so who we are. So this is our agenda. We're going to talk about who we are and then some CBH stats, our efforts around retention, recruitment, and development, and then we'll do some questions. So CBH is the local mental health authority, the community mental health program, and the community developmental disabilities program in Clatsop County. We have about 147 employees spread across 10 different locations. CBH offers the whole continuum of services, including child and family services, wraparound, intensive in-home behavioral health therapy, parent-child interaction therapy, MRSS, which is our mobile crisis response, parenting education, school-based mental health and substance use disorder services, outpatient mental health and psychiatry. Our adult services include community support services, which is like intensive case management, assertive community treatment, ACT, our general outpatient care. We operate 2 rapid access clinics or urgent care facilities on either side of the county. Medication assisted treatment. We have a full team in our jail here in Clatsop County and have a really unique relationship with our jail MAT and some counseling supports and a nurse. And then substance use disorder treatment services, peer support services, crisis, aid and assist, civil commit, forensic case management. And then we have a kind of growing portfolio of housing. We also believe that housing is just a basic part of healthcare and a human right. So we've really invested in developing this area of the organization over the past years. So currently we have 16 beds of PSH online, but come December we'll have 48 units of permanent supported housing online. We have a 16-bed residential treatment facility for adults with acute needs. We operate a 5-bed low barrier shelter for adults. We have some independent living apartments, a sober living house for women and men. And then, of course, we're the Community Developmental Disabilities Program, offering IDD and DD service coordination to the county. So where we're at. CBH, our current vacancy rate is about 2%, and our average turnover right now is around 15, which of course I would love to see lower, but we're doing okay. So just a couple of kind of caveats here. The majority of our turnover within our organization happens within our housing and residential department. And Amy kind of mentioned some of these things in the beginning of our meeting today, that this residential is an area where you see a lot of turnover. This is related to some of the funding models for residential treatment, and in that low reimbursement rates for the care that we offer end up meaning that we have high acuity clients and tough jobs that we can't pay enough for. So they're hard jobs and we can't pay them enough, and that obviously leads to some turnover. I want to highlight here that while CBH's crisis team is actually pretty well staffed, and we have pretty high retention in that department, we've done some unique things in figuring out how to keep our crisis team staffed, that it's not a great place for associate level providers pursuing licensure, as they can't acquire enough direct service hours. So, we've lost a really great manager who was pursuing his LCSW. And it's just, when folks want to do that work, it's really hard to figure out how to get those needs met when they're employed on our crisis team. So that's definitely something we want to keep thinking about. Okay. Culture. This is kind of the overlay of some of the things that I'm going to talk about today. And I just want to say that I loved hearing Julie's presentation. It's going to sound a little bit redundant, some of the things that I'm talking about, but I think what's cool about it is that the things that we're doing are the things that are working. And so some of the strategies that you'll hear me cover are really similar to the things that they're doing over there at New Narrative. So culture is probably my favorite thing to talk about when it comes to the behavioral health workforce crisis, because I think that there's so many things that we don't have control over in the system as executives of organizations. But culture is what we have control over. So we really have to make it count. So some of the things that we do here include clinical rounding. Julie talked about this too. So I make sure on a quarterly basis that I'm getting into all of our different locations and meeting with staff, having casual conversations, getting feedback, making sure they know my face, and just kind of cutting it up with people, like having a good time and making sure that folks know that I'm a real person and I'm available. We also do weekly Friday messages, and the structure is very similar to what Julie's doing. We also address things that are happening in the country and how, maybe the political climate is impacting people's health and wellness. And, we try to offer some inspirational messages there. I also have used that tool to be really transparent about our budget and about the financial climate. I think that even if the information that we have to give folks might feel like it makes people anxious, people are already anxious. So I think in the absence of that information, people, it's an information vacuum. So people are going to make assumptions and they're going to fill it in. So we just want to be really forthcoming with the information that we have, and be honest about kind of the state of the state. And it seems to work really well. One of the other elements of our culture is wellness. We really focus on having a well workforce, and I expect that our leadership model wellness. And so that includes taking time off, exercising, like doing whatever they need to do to take care of themselves. But I want to make sure that our leadership folks aren't showing up to work depleted and stressed out and frazzled and running from meeting to meeting and bringing this sort of like tense energy into the workspace, because it sets tone and that kind of energy is contagious. So we really try to model wellness within our leadership team. We prioritize retention and health over production. So of course, everybody's going to have conversations about productivity and documentation, and that's an important part of what we do. But if you have a well workforce that's healthy and the work is balanced, the production tends to come. And then we invest in wellness and learning as well, which I'll talk about here in a minute. Another element of the culture that we've created here is recruiting and retaining a diverse workforce. So I'm just going to talk about some of those strategies. We all know that it's really important to have a diverse workforce that reflects the communities that we serve. And I think that one of the things that I really want to highlight here around our commitment to a safe and inclusive workplace is that diversity is really celebrated in the organization. And we figure out ways to allow people to share and to celebrate their heritage, their ethnicity, their culture. One example is our quality director is a brilliant Indigenous woman, and she offered, that's the other piece, is that we want people to offer to share and never expect historically marginalized folks to teach as an expectation. So anyway, she's an Indigenous woman, and she offered to give a presentation to the organization on celebrating modern Indigenous experiences and contributions, and that was made available to the entire organization. It was just so well received, and so I think that celebrating piece is really critical in creating this type of culture. Accountability. We talk about the fact that we know that the behavioral health field and healthcare has not always served communities equitably. And I think it's really important that we be open and real and honest about what that has meant for people in the past and what it continues to mean for people now. And then what are we going to do about it? Like, how are we going to take that head on? And how are we going to address those things through advocacy and also maybe internal operational changes or policy changes within our own organization? This is not work that I recommend doing alone. So we've been partnered with the People's Institute for Survival and Beyond for about 6 years. We have a consultant that's kind of just deeply embedded in our operations and culture here at the organization now. But they offer undoing racism trainings, and we send staff. I have 4 going tomorrow to an undoing racism training in Portland. And it's an intensive training. They cover really hard topics. And it's a powerful program. It allows for folks to get uncomfortable with the work, and then they bring those thoughts and conversations back to the organization, and we create some process space in our people and culture committee, and it really helps to just continue moving us in the right direction and keeping this work and these conversations really front and focused. It needs to come from the top, and it also needs to be employee led. So we have a people and culture committee, and they're paid, and it's a voluntary group of folks that are really invested in this work. They, much like Julie's team, develop and recommend changes to our policies and trainings and operations. They make those recommendations directly to leadership. And it also kind of operates as an affinity group. So, with the things that are happening in our world right now, it's really been a wonderful and safe place for folks to lean on each other and just kind of talk through some of their experiences. And I attend all of those meetings. So leading by example, our entire leadership team has engaged in dedicated anti-oppression trainings. I partnered with the consultant from the People's Institute, and we delivered collaboratively a 3-part anti-oppression, anti-racist training to the entire organization the last year and a half. And so I think it's really important that executive level leadership be at the forefront of modeling and engaging in some of these challenging topics and conversations. And then we use visible symbols of welcome. We have a merch store where we sell some things, but it's a meaningful way to signal to the community that we are a safe and welcoming place that celebrates diversity. Okay, moving on. Wanting to ensure that our services are offered in meaningful ways to the Spanish-speaking community. So we maintain multilingual signage at all of our different clinics and translated materials across all of our programs. We actually use like QR codes. So if you go to any of our clinics and something is a sign is in English, there's a QR code that's right next to it that you can scan with your phone, and then everything is translated into Spanish, which has been a really effective tool. We pay all of our non-English speaking staff, that should say staff, not providers, a 10% differential, which obviously shows that we value what they bring to the organization. All of our job postings have preferences of bicultural, bilingual qualifications. We have meaningful relationships with our Lower Columbia Q Center, who's the organization that supports the LGBTQ plus community in Clatsop County. And then we show up to community events to make sure that our mission and our values are known in the community. So we marched in Pride last year, and there's some pictures. And this is just my little soapbox. I think when we do the work and we have the tough conversations and we take meaningful steps to address inequities and social disparity, the word spreads and people want to work for you. So now we're going to talk about work-life balance. At some point during the pandemic, I feel like it's probably been four years now that we've made this shift. We moved to shortened work weeks. So for our 8 to 5 facilities, our staff work 4 days a week, 9 hours. They have paid 30-minute lunches and 2 50-minute breaks. So it's really 32 hours of working time a week. Some folks have Mondays off, some folks have Fridays off, some folks have Wednesdays off. But we found that it hasn't reduced productivity, and it also hasn't reduced the amount of time that our clinics are available to our community. And it's been a huge retention and wellness tool for the organization. And then our 24/7 facilities work on 12s. And so they have 3 on, 2 off, 2 on, 3 off. We allow working from home when and if it's possible. I know, kind of after the pandemic, there was this big push to get everybody back into the office. And while I think that's really important at times, we don't do that kind of thing just on principle. We want to allow people to work in a setting that feels good for them. So we allow for flex schedules and schedule accommodations as much as we can. Paid time off. This is not an area to skimp in your operating budget. It's really important in order to keep a well workforce. And so you can see CBH's PTO accrual, and you acquire more the more time that you've been with the organization. And then 12 paid holidays. So this is how we invest in wellness and training. Our licensed providers here get $1,500 of annual training amounts to use on training that is related to advancing their careers in the field. 250 of those dollars they can use on anything of their choosing that is like wellness related. The unlicensed folks, they get $1,000 annually, and 250 can be used on anything that's wellness related. And then they also get 40 hours of paid training time in addition to their PTO packages to be used for training related things. And I would just add here that at one point we tried to open the whole pot, the whole $1,500 and $1,000 pot to all be used on wellness related activities and expenses. And it was a really well-intentioned thought, but it kind of ended up turning into like a shopping spree because it's really challenging to manage what wellness means to different people. So people were getting tattoos and buying new Jordans and like it's just, so we had to rein it in a little bit. But this is what it looks like for us right now. Okay, we're going to pivot here a little bit and talk about career advancement. CBH utilizes OHA's workforce dollars and built a tuition assistance program for folks pursuing degrees or certifications. So we pay employees who are on some kind of educational track $5,250 annually if they've been accepted into the program. That's an important number because it keeps us under taxable income. So folks just get that and it doesn't have to be taxed, which is really important if you're thinking about running this kind of program. We do prioritize individuals who are pursuing a master's degree, but to date we've had enough room to pay for folks who are pursuing bachelor's degrees as well. We also really encourage frontline staff to explore career advancing opportunities. And so our receptionists, we hope and help them become qualified or become QMHAs or CADCs and beyond if they have interest. But we pay them you know, at a clinical rate, if they're in a receptionist position and they've acquired their QMHA. And I think just yesterday, actually, I was doing some clinical rounding and I met one of our receptionists who's been with us for about 7 months, and she's bicultural, bilingual. And she was just expressing like how much gratitude she has for the organization, really offering career advancement and this like mapped out path that she has. And she was like, I never thought I would have a career, and here I have all of these opportunities. So I just wanted to highlight that because I think it's a success in regards to the clinical rounding and also in the way that we support frontline staff in their career development. We also pay our supervisors. So anyone who's not in leadership, who agrees to supervise an employee towards licensure or throughout their university practicum or internship receives $100 per paid period per person, up to 2 people for full-time staff and 3 for part-time staff. Okay.
And then Shira, just a
Pardon?
friendly time check for you.
Okay, sorry, thanks. We partner with United We Heal, which is like kind of an offshoot or an affiliate of AFSCME, and they have a really great apprenticeship program. We offer the supervision and support. They pay for the schooling. Lindsay Galinsky is one of ours here, and she's had a great experience utilizing this opportunity. And then the last slide I have here is just like the First Lady mentioned, we have a really amazing relationship with our union. I think once we figured out that, and this wasn't the case when I started at CBH, so we've really come a long way. We have shared and common goals, right? So AFSCME and CBH leadership are invested in the happiness and wellness and satisfaction of our staff. So we just information share. We're really transparent with our union reps. We let them know, you know, if there's budgetary issues, if I'm going to have to move staff around to fill critical staffing needs. And it has just, it's just kind of a beautiful thing. And so AFSCME also communicates openly with us. If the reps that work here see that something might be stirring or they have concerns about someone feeling frustrated about a change, they call me directly and we're able to just kind of partner in the care that the care and the support that we offer our employees. And that's all.
That was so great. I want to highlight something. I'll take a moment here. Just want to highlight moving to the 212s because and please jump in here, Sarah, if I'm wrong, but how I understand it. So knock shift is one of the hardest to fill. Not having consistent, and this I can speak to from my own. It's really important, and then sometimes that can mean you have the most turnover in staffing, and so that also means that when people are waking up, right, they're seeing different people over and over and over again. It is also a time where there are safety issues that come up in very different ways, and so the ability to have 2 people that are, you know, so that by changing that, they've been able to stabilize more of the residential workforce. So that increases safety for clinicians, better outcomes for clients. Full stop. And this is a problem anybody who does residential of any kind, I think, understands some of the challenges of that shift. And so this is the way that they've managed it. It's much more akin to hospital staff. It's different but it's not really what community-based organizations do. But I just know residential, it's always a struggle. And so I wanted to just call out that this has been really successful. And its success, you know, those are the same folks that ideally maybe they graduate into other programs, but it's a residential is a foundation for some of our most acute clients. And so when this works well, they just have a lot more opportunities. So I wanted to kind of draw that line a little bit because I think it's a really big deal that you've been able to do it. And I know it's just something, and it's a good thing to brag about because I think it's something for folks to be able to use in other settings. I have used it, and people are like, "That's amazing! That's a great idea."
Thank you. It's great for the health of the program and for the safety and of the staff and also for retention. It's not good for your bottom line. So again, these are the funding challenges that that have to be resolved in how residential programs are funded.
Yes, the thing I wanted to point out too about health and wellness is I have heard lots of discussions we had that are at our SMI roundtable talking about the health premiums for folks who are dealing with acuity because people are dealing with trauma and a whole lot of things. And so the healthier we can keep our workforce, the less that we're paying in healthcare benefits. So sometimes that can um sometimes that can help. So it's super exciting. This is such an exciting day. All right. Um uh, Good to see you again. Now we're gonna have Dr. Hope. Am I saying it? Sherman, Senior Clinical Educator Director of Eastern Oregon University, will present on successful strategies. Dr. Sherman is the licensed mental health counselor with a PhD in counselor education from the University of Central Florida. She specializes in childhood trauma, disaster trauma, and creative therapy approaches. She has published over 20 peer-reviewed articles, presented at more than 40 conferences, and received multiple awards for her research and teaching excellence. Uh, and if you're ready to go, we are excited for it.
Yes, thank you so much, First Lady, and thank you all for having me today. I have learned so much already, and I'm excited to hopefully contribute to the conversation. So I am going to go ahead and share. So I'm going to be talking more about education and licensing and credentialing today. And I thought I would start well, here's the obligatory agenda slide so you can see a little bit about what I'm going to talk about. A little bit about myself and mental health counseling, our CMHC program at EOU, and then the barriers, strategies, and opportunities when we think about these topics and how they're all connected. So a little bit about me, I thought it was important just to share because I'm not an LPC in Oregon, even though I run a program that's in Oregon. I am a licensed mental health counselor and qualified supervisor in Florida. I've been licensed in Louisiana and Texas as well. I do plan to pursue my LPC in Oregon probably in the next few months, mostly so I can offer affordable supervision for licensure interns. I've worked in mental health for 20 years, 15 in academia, and I've been at EOU for the last 3 years building and growing this program. So I come with an outsider perspective, but I always take feedback from my students, many of whom are QMHAs and QMHPs, our instructors, our community agency contacts. We have instructors and site supervisors that work in the rural areas in Oregon. And so some of these ideas are mine and some of them are others. And if you don't like the ideas, that's okay. Hopefully something will land and some things won't, and that it can help fuel more conversation. So when we talk about mental health counseling, I'm going to be talking about QMHAs, QMHPs, LPCs, and LCSWs and the crossover. But I do want to acknowledge that my specialty is in the master's level clinicians. A little bit about our program. We launched in 2023 with our first cohort, and the goal was to fill the gaps in mostly the rural areas in Eastern Oregon with a grow your own model, which we've already heard about today. And I think that it is a fairly successful model to get mental health providers to stay in the areas that we most need them. We approach education through trauma-informed and brave spaces frameworks. And brave spaces is really more about having those courageous conversations versus the term safe spaces, which you may have heard before. We are a fully online program. We do our residencies and our coursework synchronously over Zoom. And so far, that's going really well. We have about 150 students right now, so we're at capacity. And 70% of those are from Oregon, and then about another 65 to 70% of those are from Eastern Oregon, plus another pretty good percentage of students from other rural areas in the state. And one of the things I love most about our program is that we're about 50% non-traditional, which is students who are in their second or third or sometimes fourth careers coming back and getting their master's degree. We've been able to fund our students at different levels through an OHA scholarship fund. So we've given out $750,000 in scholarships. And unfortunately, that funding is ending this December. So we are still looking for other opportunities because many of our students are low income and work while trying to go to school. We had 13 students graduate over the summer and they're already working as LPC associates, and we have about another 25 in their clinicals. All right, so barriers are things that you all probably already know. I actually watched your substance use council meeting, and so I think some of the same thing were covered. Recently, I just stumbled across the CNN article that had the new ranking of state mental health. Oregon is at 42, and if you want the link to the article, it's embedded in here, but it talks about a lot of that being access and how quickly people get access to the providers they need. Some other barriers I think is portability. And so QMHA in particular is something that is tends to be specialized in wherever the person is getting their lived kind of experience on the ground. But in addition to that, for all of the different levels of training, the cost, the education, and then testing and registration fees. And many of my students tell me, I'm not going to be able to take my licensure exam until I'm working a year or more so that I can save up for it because those fees are costly. There are other state requirements that we have found to be pretty significant barriers. I gave one example here, and this was an administrative rule that groups mental health counselors in with other healthcare professionals, and so the requirements are quite costly for students to go through before they enter practicum. And then one thing that I know you all have talked about is the lack of qualified supervisors at all levels, and I'm going to talk about that a pretty good bit as we move forward. So next, for strategies, as I spoke about earlier, we do use a grow your own model, really trying to get people from the community they live in to fill the gaps. One recent thing that we have noticed with that is, though, imposter syndrome tends to be a little bit bigger. And so we really have to build relationships with students and help them feel confident in their new skills, especially if they're moving from like a blue collar job to a more white collar job. And that includes building the sustainable pipeline, from the associate level all the way up to licensure and supervision. And part of that is making sure that people know how to move up, a clear kind of pathway forward for anywhere starting at any point in the line and then moving up, and then also looking at earning potential. One of the things that I noticed in the guiding document for this council is that mental health counselors weren't disaggregated between QMHAs and LPCs. And we know that there's about a $15,000 salary jump from a QMHP to a licensed professional. So I think that it's important for folks to know sort of the why, not just for serving clients, but also for themselves to keep moving upward. This would also in and of itself create a more stable supervision structure and decrease burnout because it would spread out more of the responsibility as we have people moving through the pipeline at all times. One idea that I actually got from one of my students was streamlining curriculums for QMHAs for greater portability, which it sounds like there's some of that happening in other programs already. Another thing that we can think about is adding to existing structures, especially for high need specialty areas. One of the things that we are looking at, even though we don't have an addictions track in our program, is partnering with someone else in the state. So if we have students who want to maybe get the CADC or other credentials as they move through, that they could do that at the same time that they are in their class and get some credit for it too. So I think that thinking, creatively and building things in, your students are already paying for their credit hours. How do we kind of get them the most bang for their bucks could be helpful. And then finally, integrating the state level certifications with the licensure board process. I've looked at both of those websites pretty extensively. And as an out-of-state person, it's confusing. It's a little confusing. And I think about, for somebody who maybe has an associate's degree who wants to go into mental health, or even a high schooler, if they didn't have someone to kind of show them the ropes or tell them how to work through, it could be fairly difficult for them to figure it out on their own. one of my students actually, or alumni now, emailed me earlier this week and said that her QMHP had lapsed, but she had done her LPC associate registration, and she was confused about why those two things weren't connected, or how they didn't sort of like talk to each other. And I thought that was a good point, because she is working in community mental health, but also wants to earn her license. So lastly, opportunities, some ideas from brainstorming and talking with other folks, really creating a learner-centered approach that's user-friendly. Everywhere from like creating a document that clearly outlines the pipeline in mental health careers and where you can stop and why you might want to stop there, why you might want to continue on. Making sure that our systems are easy to navigate. In academia, we are definitely guilty of this. Like, our systems are hard, and we have been working to make them as easy as possible and accessible for all who want to explore those options. And then continuing to support the mental health workforce through accessible and affordable education, which I think is where things like the OHA grant was so helpful for us. And I'm very hopeful that there will be more funding to come through to support our students. Like I said, many of them are their first generation master's level students, and they're working, they have families, and they need support to move forward. Resource sharing is another thing that came up when I was talking to students and alumni. Particularly in rural areas, there is a need for more in-person training opportunities and intensive training opportunities for them to get either trained in specialty techniques or get those additional certifications. And I think that equal and equitable aren't always the same thing. And so we have to think through how to make sure that rural areas get their equitable resources. Next, the supervision continuum. We need supervisors at all levels, and that has to be incentivized. The biggest problem we have in placing our practicum and internship students is finding sites who have a supervisor willing to do it. And so we have a willing workforce, but sometimes I can think of at least 3 students right now that don't have sites, that want to be at a site, but they don't have a supervisor. So we are continuing to work with them to find a site that would work in their rural area. And then all of this does increase access for clients, because I think as we build the workforce, as we build the pipeline, we can make it easier for the clients to access both state resources, but independent practitioners as well. One of our instructors that I spoke to is an independent practitioner, runs her own private practice, and she did report that it's getting easier for her to serve state insurance plan clients, but she wishes that it was easier so she could take more clients and there wasn't that really long wait list time in between. So last, it's all connected. This is kind of a busy slide, but I just wanted to be able to show that if you address one of these things, you're actually addressing multiple of them. So you could pick any one on this list and start working towards it, and you're going to see multiple benefits, because it is all connected. And if we help clients, we're helping our practitioners. If we help our students at any level, we're helping clients. And I feel like our job is to do what we can to reduce the barriers that we can control. Lots of you have mentioned the budget, and of course, as a state institution, we are feeling that as well. And so what can we do? What can we focus on that's within our control? All right, so that's everything I have. I give my email here and our QR code for our program website, but I'm happy to take some questions or thoughts.
Fantastic. Dr. Sherman, thank you so much. I met with President Ryan recently, and I just want to underscore the important, I mean, it's really important to have a program like this in the grant. And one of the things that I remember that Dr. Ryan said to me, or President Ryan had said that I thought was really, I just want to underscore here, is that you have an online program, but the people who are going there are local. And I think that's an important piece for folks, is that like some of these, even though it's online, people want to go close to the communities that they're in. And it's also a community where people may not go to school at all. They're going to go here or sometimes nowhere. And so it's just filling a really critical gap in that part of the state. And so it's really exciting to see this. The program is really exciting, and just want to thank you.
Yeah, thank you so much.
And I should have said also it was fun. We have one. We kind of break it up with a little bit of the education with the providers. That was how it's supposed to, because it kind of switches it up a little bit. So keeps us moving around in the agenda, keeps us alert and active. So thank you. Okay. We have a little bit of time for discussion. My guess is people might have questions or follow-up things or things they want to talk about after those pretty fantastic presentations. So I'm here to use all of the time. I don't think I will just tell you right now. The next meeting is scheduled for October 23rd, from 2 to 4, and that's really all I have to say. So do people have questions, things you want to talk about? Oh, it looks like Ebony goes first. Oh, you're on mute. I do that every time, like 3 times a day.
Okay, can everyone hear me now? Thank you. I actually have 2 questions, and hopefully it doesn't seem too random. So I have a question for both Dr. Schumann, and then I have also a question for Shira. So just in terms of, one of the things that we struggle with in Oregon is we see kind of this disparity, especially for certain individuals that are coming from certain communities, primarily communities of color, who have to take various exams, whether it's for licensure or certification, 2 to 5 times. And, I know one of the things that we're trying to figure out is, how do we partner with, schools and universities to better support individuals when it's time to take and sit for an exam. And so I'm just curious around any kind of recommendations you all may have from where you sit. And then for Shira and for others, and forgive me for joining this meeting late, it wasn't on my calendar, so I'm sorry. For the workforce incentive, I know that some organizations, especially organizations that are union environment, haven't been able to leverage those incentives because they can't do it for every single position because, some folks are like, this is specific to providers or clinicians. And if we can't do it for everyone from admin or front desk staff all the way up, we're not going to touch it. So just curious around any strategies or solutions to address that piece as well, if any of those questions make sense.
I can just quickly address the first question. Thank you, Ebony. I think it's important just to first say, yes, especially national testing is culturally biased, and we know that. And I think there needs to be more advocacy on changing those practices and changing what our standards are for getting over that barrier. And it's expensive to test and retest. And our folks in rural areas have a hard time getting to those facilities. And then when they get there, if they don't pass, they have to do it all again. So yes, it's an issue. Some things that we're doing in the program is preparing our students through practice tests, which we've gotten some free practice tests, and we use those to help them prepare. Another thing that we do is really talk about test anxiety and knowing sort of your testing type and how to prepare and give those really good grounding strategies that a student can use in the moment when they're in a testing center, that I think we all know as mental health professionals, but we forget to use for ourselves, so really practicing those even when you're doing testing The last thing I would say is if you're at an agency where you can fund the practice test through websites or study groups, there are a couple that I used when I was studying for my licensure exams, and they were expensive. And I remember thinking, I wish that I could fund these like for all of our students because I think it would make a huge difference. So some sort of agency funding or group discount for those very specific web trainings on preparing for the test would be my top suggestions.
Well, and can I just thank you so much for bringing that up, Director Clark? Because I did want to just point out, if I don't know what the cost is, but there's a cost of the test, and then I know many people need to take the test prep and the various courses that go along with that, which are pretty expensive. And I don't know what those current numbers are, but I actually think it might I actually kind of want to get that and kind of package that up just so people see how much it costs altogether. I think that could be helpful. And then another thing I would point out that is interesting here around that sitting 2 years post graduation before you can take the test. And there are different, that's interesting to me. And for folks with any kind of learning disability or neurodiversity, I always wonder about what that looks like.
Is that just for LCSWs that they have to wait to test? It is, right? Okay. Because for LPCs, like for the National Counselor exam, like they're encouraged to test right like before they're really even done with school, like last day of school, because like you're gonna forget all this theory stuff. So you better get it done. So it's unique to LCSWs, and I think that's something that could be addressed. So and then Ebony, I'll respond to your question. I think you're referring to like our 10% differential for Spanish speaking providers. Is that kind of where that, yeah. We haven't had a problem with the union in that regard. Yeah, so I think that's relationship driven. You know, I think that again, like our mission is clear and our union reps are on board. I think it's hard for county shops who are union shops and something that the behavioral health sector might want to do. And you know this, Ebony, like that maybe that's not true for everyone at the county. And so they can't like roll that out across the board. And that's like a unique challenge. But I think sometimes HR directors get a little bit anxious about this kind of thing and may shut it down before it even goes to the union. So, you know, this actually came up in a recent AOCMHP meeting, and I'm encouraging my HR director to get with other HR directors across the state to kind of talk about how we got this done and to maybe reduce some of the anxieties around implementing something like this. So I don't actually know if it's the union.
I'll jump in. I can't figure out how to raise my hand, but I have two comments, and one is to Dr. Sherman too. I directed a BSW program, and I think your comment about and I was in Portland, but finding placements with supervisors was a huge challenge. So at one point we had 50% of our students where we had to either I had to supervise them or pay an outside supervisor, and we paid horribly, I'll just tell you. So it was just all moral distress. And supervision has just come up in so many of these meetings. So I just want to say I'm so glad that we're surfacing that as a barrier. The other thing, I think I'm so heartened by the present, and I'm sort of like in awe of the management presentations today. I just feel like I've never worked in an organization with people who care as deeply as um, is what we heard today, Julie and Shira and Laura. I mean, I really am just blown away, and I think we have so much to learn as a society, and like I want to take some of this to my current institution as well. But thank you for being models and leaders. It's really impressive.
Yeah, Alice, I just wanted to agree that I was like, send me your openings. Tell me where to sign up.
Yeah, and I'll add, I was thinking the same thing about how it isn't just the organizations where the clinicians are serving the patients, but the regulatory space that needs to do that. And it's the work we've been doing at the Board of Nursing, the board needing to do that, those that credential, those that like all of the steps along the way. So it was good to see those examples in the clinical space, knowing that we're doing it in all of the spaces to be successful, education, regulatory, and whatnot. And I actually took a note for figuring out how to do an intranet suggestion box, so that we don't have the old school like box sitting in the break room that nobody is in anymore. So thank you for mentioning that, Julie.
Jump in here. I wanted to bring up some of the challenges around paid internships. I think that even if an organization wants to pay for an internship, a lot of the universities still aren't allowing for paid internships, which is just nonsensical. But it needs to be addressed. Like people need to be paid for their work, even if they're in school. It's good for wellness, it's good for retention, and we want to do it. So we need to address the barriers there.
I'll
Is
just
there
say
time for me to ask a
quickly.
clear? Oh, go ahead.
I'm sorry. I was just gonna say we do allow for paid internships, and some of our students do have paid internships, and we work really hard to make that work because we agree that students need to be paid for their work.
And what I was going to add is we followed Washington and Idaho and created a nurse intern position. Um, what the barrier we ran up against is while you're getting paid, so it's great, there was no way to get credit for it at school. That was like a heck barrier. So stopped that fight and just fought having that student intern role people could hire and they at least got paid, which was helpful. Oh, please.
Did you say me? I
Yes.
couldn't.
Yes, sir.
Okay.
Please go. Yes.
Okay, sorry, my audio is being weird. So yeah, for us, it's been interesting. We suddenly have more interns than we can possibly handle, and we keep getting more. They're like refugees from other internship sites, and I'm like, well, okay, but like we 18, really? I mean, they just keep coming, but and we do pay them. But what we've found is that with certain schools, it works really well. And that's because the people are prepared and they can start delivering services. So really they're budget neutral. We can pay them, but they can deliver services and it really is just neutral. For some of the schools and specifically the social work programs, we've had a lot of problems where they're getting information that they shouldn't be delivering any services. We're required to pay people if they're working, but they can't do things based on like things that are billable. So that's a really weird issue. And so we sadly just stopped taking those interns, but we take all the other ones. And so I mean, it's a weird thing with certain social work schools. Really, only as far as what we're running into.
And I'll quickly add that I'll connect with the social worker board because we had to be very specific and clear in our rules. And I had to be very specific and clear with institutions and deans on how the process worked for nurses. It could be different for social work, but maybe there's something that could be done in that space, in the regulatory space, if it is impacted by that, like we did. But again, don't know if that's the same thing. Bethany, you don't talk very often, please.
Hi, I was just going to say, as a practicum faculty member at PSU School of Social Work, we support and encourage all of our agencies to pay our students and also support employed social work programs. But we do know for out-of-state schools that have online schools, we've heard that that's a significant barrier. But just did want to say that Portland State University highly encourages that, and we support students being paid.
Alice?
I'll just add, there's nothing in terms of the accreditation of social work programs that prohibits people getting paid. So there's nothing on that end. And I want to affirm, Summer, what you said, which is that there's a lot of like confusion and rumors about what you can and can't do. And it has changed over time. But like when I started at University of Portland, you couldn't get paid and get credit. And then like something changed 7 years ago and then you could. And so I think there's sort of the bureaucracy of accreditation also it's constant confusion for a lot of program directors. Anyway.
Well, this part is really important because we've talked about in previous meetings how these how people's practicums can help prepare them for the acuity of today. And you're a lot less anxious when you write your first note if you've done it in your practicum. And that we've really wanted to use those as training grounds. So when people start, they're much more prepared. And so that's good to know that there's differing ideas about that and about what can happen, because people are much more prepared if they have opportunity to practice. And then they're much more likely to stay in the profession when they're ready on day one. So that's some good follow-up. Okay. This has been an incredible meeting. I have to say, I'm really glad that these meetings are taped because I just want to show everybody the great work that you're doing. Because how people manage their organizations really matter. The presentations were wonderful, and an opportunity for people to learn more from you all. I want to know what Julie's last couple slides are. We'll have to maybe figure that out. So the introvert, extrovert. So just again, another wonderful meeting. Thank you so much for everybody who worked hard to make this happen. And we will look forward to seeing you at the end of the month.